Merhabalar öncelikle herkese. Ben bugün gelişimsel psikopatoloji.
Today I will be speaking about developmental psychopathology and related terms. Then I will be touching upon the current literature about continuity, and then I will move on to diagnosis. Developmental psychopathology discovers how some disturbances develop, what happens to these children, and will help us understand how to treat these children. In developmental psychopathology, it is either adaptational failure or delays, fixations, or deviance. What is important for us is to have an understanding of differences and links in terms of atypical development. Process is an important concept there because childhood psychiatric disturbances do not develop instantaneously but rather in time. Developmental psychopathologists just explain it as a difference between taking a photograph and a video. In a photograph screen, we can have a detailed look into light, color, and the details, but we do not know what the kind of light it will convert into in just a second or so. Developmental pathways are actually the principle of adjustment and maladjustments in points or places along the lifelong map. There are some links in between. Actually, when we take a look at the developmental pathways, developmental psychopathologists emphasize the fact that development is cumulative, is built upon itself. Secondly, developmental pathways are probabilistic, not deterministic. Therefore, every problem may not lead to disturbance or developmental problem. There is a consistent progression of development, and the type of behavior may change in life. However, in terms of physical abuse, let's see, the children being physically abused by older brothers may impose physical violence to children who are younger at school, which is a coherent behavior. Looking into developmental psychopathology, factors of competence and incompetence are important factors. Competence is an effective functioning in important environments. There are some components and characteristic features in childhood, like the skills of the child. And we can speak about competence and incompetence factors relating to models, which I will not be able to discuss due to time limitation. Risk is defined as an increased vulnerability, but today I would rather focus on the term continuity. Childhood psychopathologies, as discussed by the previous speakers, are continuous, but there are two types of continuity. Homotypic and heterotypic continuity. Homotypic is rather about a consistent remaining behavioral pattern or expression in time. Heterotypic continuity is rather a developmental process in which an individual's underlying problems remain consistent but manifest in different behaviors over the course of time. In time, there can be a change in the implication of the behavior. When there is anxiety before school, it may also be converted into the factor. This is a current literature about continuity for any kind of diagnosis at the age of 3. If the children meet the diagnostic factors, it's 5 times as likely as meeting diagnostic criteria at the age of 6. Attention deficit hyperactivity disorder and oppositional defiant disorder are important in terms of continuity. Also, depression to anxiety, from anxiety to oppositional defiant disorder, from ADHD to heterotypic disorders, there is a continuity. Another study that looks into the previous psychopathology before school. Almost half of them would present with some kind of psychiatric disorder at the age of school. And from the other corner, more than 1/3 of school-age children and early adolescents with psychiatric disorders meet diagnostic criteria in early childhood. A very important, I think, and specific finding of this study is the homotypic continuity externalizing disorders are more than internalizing disorders. The same study also discusses the fact that preschool anxiety disorders predicted depressive disorders. In a larger scale social study, homotypic continuities are strongest for ADHD, moderate for behavioral disorders, and for anxiety and depression. And regarding the heterotypic continuum, ADHD symptoms increase later, the anxiety symptoms, whereas ODD increased the other symptoms. In early childhood, when there is a diagnosis, in social functionality and in all the fields of social functionality, except for relations with the father, there is an increase. Externalizing disorders predicts impairment in more fields than internalizing disorders. Let's take a look at the literature in terms of categories. In terms of autism spectrum disorder and early atypical ASD, diagnosed before the age of 3, they remain remarkably stable over time, but after the age of 4, diagnoses show increasing stability. Multiple social developmental problem children or infants at the age of 12 have a higher risk of developing ASD, but the course of EAASD is not known. At the age of 18 months, hyperactivity and also impulsivity are not predicted at high levels, but at moderate levels. In younger children, the persistency of diagnosis over time is quite good, but the symptom clusters are inconsistent in time. We also know that especially in younger children with ADHD, academic problems and learning disorders are a higher risk. The ADHD symptoms in younger children are the precursors to later behavioral disorders as well as depression. This study is about anxiety or autism spectrum disorder and attention deficit hyperactivity disorder. Increased activity level and poor inhibitory control were found to be associated with ADHD. Increased fear and shyness were associated with anxiety symptoms as well as ASD. However, in terms of the further analysis, association between shyness and anxiety became insignificant. When ASD symptoms were also controlled for, the association for anxiety is quite weak. Also, there are studies about temperament traits. In about 10 years, ADHD symptoms were predictive in the presence of a thoughtful control and activity level. Activity level showed specificity only for the hyperactivity and impulsivity symptoms, while EC was predictive for both symptom domains. Also, early childhood children were assessed in terms of adolescent cigarette, alcohol, and marijuana use in another study. And compared to the control group, this group started abusing these substances earlier. Another developmental problem is the language disorder. Those presenting with language disorders at the age of 5 were compared to the control group and implicated that they were followed for 26 years. Higher rates of subthreshold social phobia was present at the ages of 19 and 25 years and confirmed higher levels of social interaction and anxiety symptoms at the age of 31 in this group of individuals. Sensory over-responsivity. It's found to be an early risk factor for anxiety and behavioral challenges in young children. 43% of preschool children with sensory over-responsivity also had a comorbid impairing anxiety disorder. Between the ages of 1 and 8, Sensory overreactivity disorder symptoms showed a moderate stability. In average, all young children show an increase in sensory overreactivity behaviors between 1 and 3 years of age, and the course of sensory under-responsivity disorder is unknown. Anxiety disorders. As for anxiety disorders, those children meeting diagnostic criteria at early childhood also met anxiety disorder criteria at the percentage of 50% during the ages of 7 to 15. Homotypic continuity for social anxiety disorder, separation anxiety disorder, and generalized anxiety disorder were found to be associated with specific phobia. This study also relates to prevalence and course of anxiety disorders and symptoms from preschool to adolescence. Heterotypic pathway from an increase in the number of specific phobia symptoms in early childhood to an increase in the number of GAD symptoms in middle childhood. This one, the subjects were included at early childhood, and 4 different groups of trajectories were associated. Higher internalizing but not externalizing behavioral problems were present, worse academic achievement and worse developmental health, overall health were present. Inhibition to novelty disorder is not an area that we have a lot of information about. Nevertheless, current opinion is that this disorder is a type of anxiety disorder that would have an onset at the age of 3. Those children with a preschool depression history were assessed in comparison to peers in terms of depressive symptoms, were found to have elevated levels of depressive symptoms all along the way. Preschool onset depression predicts major depressive disorder and other psychiatric disorders in later childhood and early adolescence, according to this study. And also children with preschool onset conduct disorder were more likely to be diagnosed with school-aged ADD. Excitability and irritability in preschoolers predicts later psychopathology. At the same time, we can expect until adolescence a global functionality prediction. Also, this study is about 2 groups of subjects with or without emotional dysregulation. Those presenting with emotional dysregulation in early childhood present with a higher digital media use at later ages. At the age of 9, in terms of gaming disorder, there is a higher prevalence. Also, in terms of self-regulation,
Stabiliteye baktık. Bu bir yeterli.
in terms of self-regulation in childhood as a predictor of future outcomes, achievement, academic success, and interpersonal relations are also affected accordingly. The course of early childhood OCD varies, although persistence of an OCD diagnosis of partial OCD symptoms is common. We have some preliminary data predicting that girls, young children with comorbid oppositional defiant disorder, and young children with more severe symptomatology are at higher risk for persistence into adulthood. Also, current data show us that OCD children with comorbid tic disorders will have a higher remission rate in adulthood. Trichotillomania, also we don't know a lot about. Sleep disorders. And this study is about the children at the age of 4.5 years, 9 years, and 18 years. They've checked also the persistence of symptoms in between different ages. 4.5 years, sleep problems were more common. Until the age of 9, there is a 9 to 10% persistence rate. In terms of persistent insomnia, at the age of depression, 9, depression, externalizing, and ADHD symptoms were more common. And at the age of 18, internalizing symptoms are more common. Persistent sleep movement was associated with externalizing and ADHD at the age of 18. Sleep duration at 3, 8, and 24 months of age were associated with inattention at the age of 5. At 24 months of age, parent-reported sleep problems were associated with both inattention and hyperactive symptoms at the age of 5. This study is taken from clinical sampling with sleep disorders. 795 children were included at 2 different time points, like 4 and 6 years. These children were assessed. Insomnia and sleepwalking were stable. Also, insomnia increased the risk of developing symptoms of CD, MDD, and social phobia. And also sleepwalking predicted later separation of anxiety disorders. In terms of eating disorders, binge eating was also assessed at the age of adolescence. Persistent undereating was associated with higher anorexia nervosa risk in adolescent girls, and persistent fuzzy eating was associated with greater anorexia nervosa risk. Children who cried excessively in infancy had a higher parent-related internalizing and externalizing symptom score throughout childhood versus peers. As for trauma, stress, and deprivation disorders, we do not have a long-lasting PTSD symptomatology trial, but evidence at hand indicate that after exposure to trauma within the first 2 years in infants and small children, there is no loss of symptomatology in terms of PTSD. In terms of adjustment disorders, we don't have sufficient evidence. This one is a relatively new study, especially abuse at childhood at all scales are associated with social anxiety disorders at adulthood. In terms of behavioral disorders, reactive attachment disorder signs are manifested in infants to associate with the responsive engagement disorder. The symptoms are responsive and regressing. In terms of relational disorders, we don't have sufficient data. It's just thought to be continuous. Thank you very much for your attention.